Good morning. I'd like to get started on this Scapholunate and more session. Our first speaker is Margaret Falk from Hong Kong, Diego Fernandez, a new entity of carpal instability, non-dissociative after wrist fractures. I'd also, it'd be nice to have a microphone. I'd also like to introduce my co-moderators, Wei Yin and Martin
Wells. Thank you.
Good morning. Thank you, Chairman. So thank you for the opportunity to give us this opportunity to talk about a new entity of carpal instability, non-dissociative, after wrist fractures. So when we talk about carpal instability, non-dissociative, we are talking about the dysfunction of the entire proximal rod with no separation within the proximal carpal rod. And so conceptually, it is caused by the radial carpal ligament insufficiency. So we all know the carpal instability, non-dissociative, that is divided into the symphysis, the DISI, and then the combined and the adaptive, which is mainly talking about the distal radius fractures and extra-articular distal radius fractures. And after that, you have adaptive malalignment. Then Diego Fernandez further described them into type 1 adaptive DISI and the type 2 fixed DISI. But we didn't really talk about anything about intra-articular distal radius fractures. So for example, this is a 30-year-old guy with a distal radius fracture after a motorcycle accident with close reduction and percutaneous pinning. You can see that there's satisfactory alignment after the pinning. However, when we take out the pins, you can see that the lunate goes into like a fuzzy kind of malalignment. This is another 36-year-old guy with left distal radius fracture after a motorcycle accident. We do a screw fixation for that. Yet, 4 weeks or in 7 weeks postoperatively, you can see that it is more like a disease deformity. So we actually collected 12 patients with this kind of stint after acute intra-articular fractures between 2013 to 2018. All of these patients have high energy trauma, and 9 of them is intra-articular fractures, and 3 of them is radial carpal fracture dislocations. You can see the age is 32 years old, and 10 of them go into symphysis, and 2 go into DISI. So we try to understand why that will happen. So we did some cadaveric dissections, and we find that when we cut the short radial lunate ligaments, or when there is a high energy trauma, which we have a fusion of the volar rim or the fusion with the short lunate ligament, when we put in an axial load and dorsal shearing load, we will actually rupture the radial carpal tricuspid ligaments as well. And then and because of the intact of the RSC and also the long radial lunate ligaments, the whole rod will go into, will flex and go into a fuzzy kind of malalignment. For DISI, it's actually more because of the volar radial carpal extrinsic ligament injury combined with an intra-articular incongruity of the scaphoid fossa, so that we actually didn't really reduce it completely right, and so therefore we have a persistent DISI deformity. So out of the 12 patients, 4 of them have mild pain and 8 of them have severe wrist pain. So with that 8 patients, 3 of them were able to be reduced, and so we did open capsular repair and temporary radial carpal fixation, transfixation with KYs. And 5 of them, we cannot reduce them, and so 1 of them is a DISI and 4 of them is a fuzzy. So we did a radial scapholunate arthrodesis. We have a follow-up of a minimum of 15 months to 4 years, and all of them, with the 8 patients, they all have pain relieved, and the improvement in range of movement, especially with the reducible ones, have good improvement in range of motion. They have a good improvement in the grip strength, and X-rays alignments were able to maintain at latest follow-up. So this is a case that we first talk about. You can see that there's the fuzzy deformity after we remove the pins. And because it is a fixed deformity, so we did a radial scapholunate fusion. And this is at 1 year postoperatively. And you can see that there's good range of movement afterwards. This is the other cases where it goes in the fuzzy. So at 3 months, the patients have actually, we look at it and we can see that it is an intra-articular malunion, and the patients have severe pain with limited range of movement and decreased grip strength. So this is the CT that we do post-op. We try to analyze the malalignment. And so with that, we do a radial scapholunate arthrodesis with distal scaphoid pole resection. And afterwards, the patients want to have some more movement on the tricutril side, so we did a resection of the tricutril at 6 months later. This is another patient with a 28-year-old gentleman with motorcycle incidents. You can see that it's a radiocarpal dislocation. And, and we did a post-reduction, and then you can see in the CT there is rims, avulsion of both the dorsal rim and the volar rim as well. So initially, we just do a palmar ligament repair, and that is and we do immobilizations afterwards. However, the patients continue to have limited pain. And then we look at the CT, actually, and then we look at the X-ray, it's actually going to a FESSH. So we did a reduction with KY fixation. And that's 5 weeks. And at 4 months, the patients have satisfactory range of movement. This is the last case with the patients with intra-articular fracture distal radius and with plate fixation. And you can see that this one, actually the patient have limited range of movement, but it is because of the screw protruding into the RUJ. So we actually and the patients have limited range of movement because of that. So we actually just take out the screw, and then at the same time, take out the plate, at the same time we do a scope, which find that the SL and LTs are intact. So it's not actually a disease. So with that, we actually just remove the plate, and the patients have 3 months, 3 years post-op, you have satisfactory range of movement.
Maybe no question.
So in conclusion, we think that this is a new entity of SINT after intra-articular distal radius fracture, which we haven't talked about or we haven't been mentioned about in the literature. It is only in a selective group of patients, usually in the young patients with high energy trauma. We need to have early detections, and if we can detect them, we can preserve the joint mobility by doing capsular repair. And in cases of fixed deformity, limited radiocarpal fusion is recommended. So thank you, and thank you, Diego, for the talk.
Thank you, Dr. Falk. We have one quick question. I'd like to ask it. We've seen the same deformity in scaphoid fractures,
yes.
SINT, dorsal, volar. How can we detect this early and act on it?
I think sometimes it's difficult. I mean, I think we need to think of this as most of the cases that we've seen is young patients and high energy trauma. So we just need to be, in the young patients with high energy trauma with distal radius fracture, we actually need to think about that it is not just a distal radius fracture, but we need to pay more attention to all the ligaments and actually see whether there is significant instability. And some of them we do need to have scope in, and then actually and pay more attention to it. So yeah, maybe wrist arthroscopy is a good option, especially in the scaphoid fracture cases.
I would agree. Thank you.
Thank you.
Okay, may I introduce the next speaker? Ahmed Naim Atiyah from Egypt. The topic is new ligament reconstruction for metacarpal instability, a case report.
Thank you.
Thank you. So I'd like to call on Dr. Byung-Sung Kim from South Korea, arthroscopic treatment for isolated traumatic lunar triquetral ligament injury without TFCC lesion.
Hi everyone. I'm going to present about the arthroscopic treatment for isolated traumatic lunar triquetral ligament injury without TFCC lesion. Lunar triquetral tear occurs by radial side force with wrist extension or deviation. The cadaver study shows that the tear exists 27.6% over 60 years old, but no tear under 45. The diagnosis for LT ligament tear, localized tenderness and ballotment is positive. MRA is helpful. Primary treatment is conservative. Purpose was to evaluate the clinical result of the patients treated with arthroscopic debridement and thermal shrinkage of the isolated traumatic lunar ligament tear without TFCC tear. We found 12 patients with isolated traumatic LT membranous portion tear retrospectively. The mean age was 30 years. All the patients underwent MRI. Inclusion criteria was persistent all-side wrist pain with definite trauma history after conservative treatment and more than 6 months follow-up. We exclude combined TFCC tear and complete LT ligament tear. Mechanism was sprain 6, fall 5, and boxing 1. Average duration from trauma to surgery was 5 months. For the evaluation, we measured all variance and all dorsal subluxation. Repower, DASH score, and Mayo wrist score was checked. Results. Preoperative MRI did not show LT tear in all cases, except DRUJ subluxation, lunate bony contusion, alasteroid bony contusion, and the dorsal scapholunate ligament occult ganglion. Physical examination shows the ALA stress test in 8, DRUJ stress test in 7, and Ballotman test in 7. Preoperative ALA variance was 2.6 millimeter, and ALA head dorsal subluxation was 1.0 millimeter. LT tear type was flap tear in 10 and buccal handle tear in 2. VAS score was improved from 4 to 1.5. Grip power was improved from 66 to 81%. DASH score from 36.8 to 7. Mayo wrist score from 68 to 87. 11 out of the 12 was more than good. Complications: 2 patients experienced ECU tendinitis. Cases: 23-year-old male with ALA wrist pain after trauma. MRI was normal. Arthroscope shows the LT flap tear treated with thermal shrinkage. 33-year-old female with ALA wrist pain after trauma. MRI was normal. Arthroscope shows LT flap tear treated with thermal shrinkage. A 42-year-old male with ALA wrist pain after trauma. MRI did not show definite tear. Arthroscope shows the LT flap tear treated with thermal shrinkage. A 42-year-old male with ALA wrist pain after trauma. MRI did not show definite tear. Arthroscope shows the flap tear without definitive mid-carpal step-off. A 35-year-old male with ALA wrist pain after fall. MRI did not show definite tear. Arthroscope shows LT buccal handle tear treated with thermal shrinkage. 19-year-old male with ALA wrist pain after trauma. MRI shows lunate bony contusion. Arthroscope shows the LT bucket handle tear treated with thermal shrinkage. Discussion. LT ligament membranous component tear is hard to tell whether it is torn or not unless fluid signal intensity traverses the ligament. Negative predictive value is about 85% on an MRI and 95% on provocative test. MRI was more specific. Clinical examination was more sensitive. LT Ballotman test and ALA stress test was positive in all the cases, even though TFCC was intact. So the mechanical irritation or teared flap between the TFCC and LT ligament may be related to the patient's symptom rather than LT instability. Debridement is sufficient for no instability without partial tear, and electrothermal shrinkage can relieve pain through denervation effect. Degenerative LT membrane changes exist in 50% of ALA infection syndrome patients. Associated TFCC wear and positive ALA variants may be treated with wave resection or ALA shortening osteotomy. A case series of post-traumatic isolated LT interosseous ligament tear treated with ulnar shortening osteotomy was reported with good result. Limitation is small sample size, retrospective chart review, and we did not use MRA. Summary, LT ligament tear should be differentiated from TFSH lesion when the patient is presented with ulnar wrist pain because MRI cannot detect LT ligament tear. Arthroscopic debridement and thermal shrinkage for the treatment of isolated traumatic LT ligament tear can reduce pain. Thank you.
Thank you very much, Dr. Kim. One question from the audience invited? Yes, sir.
Not only shrinkage and debridement, but repair, true repair.
Because membranous portion tear did not make any instability. It's a minor instability. So I think the symptom is related with mechanical irritation rather than instability. That's the reason for not repairing the portion.
Short question, what do you think reduces the pain in these cases? Is it a denervation?
Actually, thermal shrinkage makes some denervation effect, but I think the mechanical irritation has more effect than the denervation, I think.
Well, thank you very much for that interesting article.
Our next paper will be delivered by Jahina Reiderer, excuse me if I mispronounce, Chronic Isolated Lunotriquetral Instability, Biomechanical Testing of the Bernese Surgical Treatment and Review of the Literature.
Good morning, ladies and gentlemen, dear Chairman. I'm honored to be here today and to be able to present this presentation to you. Lunotriquetral injuries are relatively rare. They are therefore less well examined and less understood than other carpal injuries. There are several treatment options found in literature, depending on chronicity and stability. In acute cases, treatment includes immobilization, but also arthroscopically assisted stabilization and direct open repair. In more chronic cases, treatment including transfixation with K-wires, debridement and thermoshrinkage can offer long-term symptom relief. In unstable lunotriquetral injuries, arthrodesis has long been the treatment option of choice. However, it's associated with a high non-union rate as well as a high complication rate. Further, it's assumed that through arthrodesis there is more strain on the adjacent scapholunate and lunocapitate joint. Better results are reported with a soft tissue reconstruction, including capsulodesis or ligament augmentation, using part of the extensor or flexor carpi ulnaris tendon to stabilize the joint. This is, however, a more demanding procedure, and also, depending on the technique, has quite a change in the natural anatomy. With the bone ligament bone reconstruction, we imitate the natural anatomy with a graft of the capitohamatal joint. It's a rather simple procedure, but despite knowing that the palmar part of the ligament is mechanically stronger, we only reconstructed the dorsal part. This allows us a single dorsal approach, and in the clinical setting has already shown good results, but more to that later. So in our study, we wanted to find out if the bone ligament bone reconstruction can restore the natural kinematics of the wrist. Further, we wanted to assess if the arthrodesis leads to increased intercarpal motion in the adjacent scapholunate and lunocapitate joint. 10 cadaveric forearms were examined, and the tendons involved in wrist motion and clenched fist were identified and ridded of the adjacent muscle and tissue. Calibrated tension springs were attached to the according tendons for each position. In total, 5 computed tomography series were done. First, the native state was examined. Next, the dorsal part of the ligament was sectioned, followed by the palmar part, leading to a total disruption of the LT ligament. In the 4th series, the lunate and triquetral joint was fixated with a compression screw, simulating arthrodesis. In the same step, the reconstruction was performed. For the last series, the compression screw was removed and the reconstruction was tested on its own. For the bone ligament bone reconstruction, a graft harvested of the capitohemiatal joint and part of the lunate and triquetrum was removed and the graft was fitted in. It was then fixated with 2 cortical screws. In order to withstand biomechanical testing, we also did a cerclage using a microsuture to simulate consolidation. The CT images were then reconstructed into 3D models, and the software CASPA then calculated the change in angle relative to the intact state. For the analysis, intercarpal motion in the y-axis was calculated as the difference of change between the lunate and the triquetrum, the scaphoid and the lunate and the capitate. After sectioning of the dorsal part, only minor effects on kinematics could be observed. Additional sectioning of the palmar part showed greater changes. Interesting is especially the change after arthrodesis, because through arthrodesis, the position of the lunate changed quite a bit, leading to increased intercarpal motion in all the joints. After removing the compression screw, the difference of change approached the results of the native state. So, unfortunately, only a tendency, but no statistically significant reduction in intercarpal motion could be observed after the bone ligament bone reconstruction. However, despite the small number of hands we had, there was increased intercarpal motion in the adjacent scapholunate and lunocapitate joint after arthrodesis. This altered strain might lead to early onset of arthritis. So much to our biomechanical study. This technique has already been used in the clinical setting and has shown promising results, but we will hear more about that in the next presentation. Thank you very much.
Thank you for this interesting technique and presentation. My question would be, as you said, and we know, the volar ligament is more contributes more to stability. Have you tried this from a feasibility study from the volar aspect as well?
No, we haven't tried it from a volar aspect.
All right. Thank you very much. And we look forward to the clinical presentation next.
Okay, the next topic also about this technique. The clinical result will be presented. The presenter is Tom Adler.
Good morning. I'm from the same team, and it's a pleasure for me to present the operative technique more in detail, as well as show some clinical results. So, as we all know, as we already stated, the palmar part of the LT ligament is the strongest and functions mainly as a translational restraint, whereas the dorsal part functions mainly as a rotational restraint. So imaging for LT instability, if we suspect an LT instability, we do some X-rays and dynamic X-rays. However, the signs in dynamic X-rays can really be minimal and can be overseen some instability there. That's why we go for MRI, but as you already heard, the MRI doesn't give you a really 100% security in order to rule out if there's any ligament injury. That's why the arthroscopy is the next step, and then we go for an arthroscopy and see whether there's really an instability seen in the LT interval or not, and if the LT instability is not really convincing, or the patient beforehand the surgery is not really an LT instability, for sure we go for temporary stabilization with K-wires and see how the patient will do afterwards, and if the pain decreases afterwards, then we go for our reconstruction technique, what's already presented there. So what's the idea about our reconstruction technique? As we already said, the palmar part is the strongest part of the LT ligament, but in our point of view, the reconstruction of the palmar part might not be the easiest one in our hands, and that's why we thought about going for a dorsal approach with one single approach for harvesting the graft as well as setting in the graft in the LT interval. So for the approach, we go for a dorsal approach, opening the fourth extensor compartment expose the dorsal wrist capsula, leaving the radiocarpal or leaving the radiotricutal ligament as well as the dorsal intercarpal ligament intact, and indicated the capital hamate joint with its ligament and as well as the lunatricutal interval. Then we harvest the graft, leaving at least 50% of the ligament intact. That means with a chisel we go in, and normally you have at least 4 to 4 millimeters in square of each bone block left with the ligament inside, and then we fix that whether with a 1 millimeter screw or 1.2 millimeter screw on each side after we transfixed that interval with a headless compression screw. After consolidation of the graft in the bone, we remove the screw and let the patient range and weight bear afterwards. So far, it's a small number of patients. It's a rare diagnosis, despite in that not that small hospital. We have 5 patients, 4 men, 1 woman, with isolated chronic LT instability, and followed them up at least 6 months, and the longest period was 6 years. We assessed the range of motion, the grip strength, Michigan hand questionnaire, DASH score, and X-rays, including stress views. So all patients didn't show really a significant osteoarthritis during the 6 years follow-up. In the maximum, 3 of the 5 headless compression screws were removed and didn't show any instability in stress views. As you can see here on the right side, there's a picture at the patient 6 years post-surgery without any removal of the headless compression screw. The screw was fractured, and you see a loosening there. And in the stress view, you see 1 millimeter opening. So he was quite surprised about the information that something is not really perfect in his wrist, because he worked as a sanitary installer, played tennis on a regular base, and he was second worst in the final DASH score as well as the Michigan hand questionnaire. Another patient, he did the worst questionnaire in the end. He had the nerve irritation of the dorsal branch of the ulnar nerve due to the K-wire fixation irritating the nerve, and that resolved after removing finally the headless compression screw and neuralizers. He went back to his manual work, but as you see, not the best score results there. But in conclusion, you can see on average not that worst results, especially improving the grip strength. The DASH score improved on average despite these bad scores for the 2 patients to 33, and the final Michigan hand questionnaire showed up to 100%. 2 patients 100%, the 3rd patient 92%. So as a discussion, in our point of view, it's a reasonable technique, despite we know the palmar part is the strongest part, but you can do it with an easy reconstruction. You can do it with a single approach. You can harvest the graft on the dorsal side, put it in the dorsal side, and that shows some, in this at least 5 patients, good results in the end, and you still have the option for an arthrodesis if that doesn't work in the end. Thank you.
Okay, any question from the audience, either for the biomedical study or the clinical study? Any questions?
So I just have a technical question. How much of the lunate and triquetrum do you remove in order to place your graft?
So in fact, the graft, each bone block has 4 to 4 millimeters. Perfectly should be a cube for 4 and 4, and that size we remove in the triquetrum as well as in the lunate in order to just fit in like a bit of a compression with the graft, and then we fix it with screws. So it's about that. Yeah.
Thank you very much for this presentation. Can I ask why you didn't remove the 2 screws? Because you removed in 3 patients, but not in 2. But then it's not the same procedure. It's almost like an arthrodesis, or similar to RSL procedure, the scapholunate. So it's not the same reconstruction then.
Yeah, it's true, yes. These two patients were the first patient we treated 6 years and 5 years ago, and one patient refused to get the screw removed. The second patient lost to follow up, and I tried to contact him later on in order to follow them up, and then he came with that fractured screw there. Yeah.
Thank you.
Thank you very much for an interesting paper. So we switch to ganglions and call on Dr. Pierre Crozet. Arthroscopic surgery for recurrence after wrist ganglion excision. Series.
Thank you to the Congress to give me the opportunity to present this short work, talking about recurrence and with a series of 12 arthroscopic procedures. The main issue of this work was very simple. Is the risk of recurrence higher for patients that have been previously operated for a ganglion? We know the risk of recurrence after a first excision is around 10 to 15%. But what is the risk of recurrence after a second excision? I reviewed 12 arthroscopic procedures for 12 patients over a 5-year period. I included only dorsal ganglion recurrence. 11 patients that were previously operated were operated open, and 1 with arthroscopy. It was the first recurrence for 11 patients and the second one for 1 patient. The period between the surgery and the recurrence was less than 1 year for 7 patients and between 2 to 5 years for 4 patients. I used a common arthroscopic procedure with 2 midcarpal portals. The first step was an incision of the transverse midcarpal ligament, then an extraarticular excision of the ganglion, first between the capsule and the extensors, and then between the extensors and the retinaculum. An extensor synovectomy was performed as necessary. The mean follow-up at last examination was around 2.5 years. All the patients were improved after surgery for motion and function, but 1 recurrence occurred after 6 months. The only conclusion possible to tell you is to tell you we need more data to conclude. My personal opinion from this work is the risk of recurrence may not be higher after a second excision, but we need additional studies to be sure. Also, recurrence seems to be higher during the first year, so performing an ultrasound examination between 6 to 12 months after the surgery may be a good option. Thank you for your attention.
Thank you for your interesting series. We invite questions from the audience. May I start? Just asking, what do you believe the etiology is of your dorsal ganglion? Do you think it's a degenerate situation or an instability of the scapholunate ligament?
Honestly, I don't know. My opinion is more degenerative, but I have nothing to be sure of that. So the other question is how to be sure this is a recurrence or another case. When I see the patient and I explain the risk of recurrence, I tell him I will operate the right wrist, but I don't prevent a ganglion cyst on the other wrist. So is it a real recurrence or is it another case of ganglion cyst? This is difficult to answer.
I have a question. If you would, I'm curious as to why you used mid-carpal portals for what would normally be considered a radiocarpal problem. And in doing so, do you not disrupt, you called it the transverse midcarpal ligament. I assume you mean the dorsal intercarpal ligament. Does your technique not disrupt that in order to take out your ganglion?
I use the midcarpal portals because I do a personal ultrasound assessment before the surgery for each case. And if you observe the ganglion, most of the time it's straight back to the midcarpal joint, but it's true that it comes from the radiocarpal joint. So I find it easier to use midcarpal portals. It's, for me, the shortest way to go outside the joint into the ganglion. But it's true that you perform an incision in the dorsal ligaments at this point. And it leads probably to a longer recovery for the flexion of the wrist after the surgery. But this is the reason I use midcarpal portals, because when you do the ultrasound, it's straight back to this joint.
Okay. Any other questions? Thank you.
Thank you.
All right, our next speaker is Ricardo Kempf, who will be speaking on arthroscopic resection of the volar wrist ganglion, surgical technique, and a prospective series of 39 patients.
Good morning. My name is Ricardo. I come from Brazil, and I will show you how to treat the volar ganglions by arthroscopy. This is a multi-center prospective series done in Brazil and Spain. How you know, ganglion cyst is the most frequent tumor in the wrist. About 20% are located at the radial volar side. Usually, they cause few symptoms, and the treatment is mostly non-chirurgical. They came by a mucinous degeneration of the joint capsule, and there are two portions, the extracapsular portion, the pulpal nodule, and the intercapsular portion, the pedicle. Most of the patients have no symptoms. When there are pain, it could be instability or neurotendinous compression. Conservative treatment is the first option, and there are some patients that maybe complains about the cosmetics. Ganglion cysts start to be treated by arthroscopy by Lee Osterman in 1995, only for dorsal ganglions, and by P.C. Ho in 2003 by treating volar ganglions. And there are a lot of advantages: less pain after the surgery, less scar tissue and stiffness, faster return to work, and does not increase the complications rates. And the surgery consists in the compression, drainage, and resection of a piece of a joint capsule. A complete resection of the cyst is not needed. Here, a common patient that we see in your consult, a ganglion cyst, and the MRI shows the ganglion cyst and the pedicle came from the radiocarpal joint. We start the surgery highlighting the cyst contour with a skin maker pen. This will show the exact size and the localization of the cyst. You use a 2.7 millimeter optical and the standard portals to the wrist, 1, 2, 3, 4, and 6R. And you use a one blade of 2.9 shaver. Here the traction tower and the cyst contours with a marker pen. After that, we resect a small window of the capsule between the radiocarpal ligaments where the pedicle is located. Most frequent between the radioscaphocapitate and long radiolunate ligaments. External compression of the cyst facilitates finding the pedicle. Some authors use the methylene blue to easier find the pedicle. Here the view, if you use the optical in the 3-4 portal, you easily find this place between the ligaments. All this technique you can see easily in the Dr. Matulan books. Here, the procedure is doing for 2 portals, the 3-4 and 1-2, and the other doctor make the pressure of the cyst, external pressure, to easily find the pedicle. Here you can see a video that you can easily find this pedicle between these 2 main ligaments, the radiocarpal ligaments. So you only put the shaver between this ligament, and the cyst can be drained and cleaner. And after that, you do a window between these 2 ligaments. And leave this window open for the drainage continues moving. Here the 4 steps of this procedure: drainage the cyst and make the window and leave the window open. From the 2015 and 2017, you made 39 patients with this technique. The inclusion criteria was 4 months of pain and functional impairment, no improvement by conservative treatment or cosmetic complaints. The exclusion criteria was topography distal to the flexon wrist crease, patients with degenerative change, and less than 6 months follow-up. Here, one patient with the cyst distal to the crease of flexion of the wrist, and the MRI shows that the pedicle comes from the STT joint. This kind of patient is not included in your paper. The mean age was 42 years old. 37 patients reported improvement of cosmetic, complete functional recovery, and pain improvement. 2 patients have mild positive operative pain, and 1 patient have subcutaneous hematoma. There are no recurrence or infections, and no patients required further surgery. Here, one of our complications, subcutaneous hematoma after the surgery. In conclusion, the arthroscopic resection of volar ganglion cyst is a useful and safe technique. It's a minimal invasive procedure with low morbidity and very few complications. It represents a good alternative to open techniques. Thank you.
Thank you. Are there questions from the audience? Hearing none, I'll ask one. So I'm surprised. Oh, Diego, please.
What about the radial artery? Every time I've operated one of these, sometimes the artery passes through. And when you're coming in from the joint, do you ever see the artery?
No. You haven't seen the artery.
What about the hematoma you had?
Yeah, you probably pick up some branch of the artery.
Some branch. Okay.
Yeah, but you can put the shaver too deep inside that hole that you made in the capsule.
Okay, that's dangerous.
Excuse me?
That's dangerous.
Yes. But open is dangerous too.
Yeah, I think it's an important point. Obviously, there's lots of vascularity. So I'm surprised that you found only 1 ganglion from the STT joint. Other series have reported.
That was the exclusion criterion.
I see. Yeah. So you then need an MRI scan for each of these? Do you do it in every patient? Because
every patient.
Sometimes a volar ganglion will have a dorsal stalk all the way around. So
we have one patient by Gustavo Mantovani but all this series we have a MRI.
So
before the surgery.
Everyone gets an MRI?
Yeah.
Okay, all right. Any other questions? All right, thank you very much.
Thank you very much.
Okay, the next topic is also about wrist ganglion. The speaker is Elizabeth Ribeiro from Portugal. The topic is arthroscopic treatment of dorsal wrist ganglion, influence of dorsal capsullosis.
Thank you very much. Good morning for everybody. I'm talking about arthroscopic treatment of dorsal wrist ganglia. I have no disclosures to make. Dorsal wrist ganglia are the most common soft tumors in the upper limb and in the upper extremity. In most of the cases, they are anatomically related to the SL ligament, and they could trigger some instability of the ligament too. But actually, we don't know if they present as a cause or a consequence of this potential instability. Currently, most of the surgeons prefer arthroscopic resection due to its major advantages, for instance, fast functional recovery, less morbidity, and the possibility of treating associated lesions. However, we are still struggling with some recurrence cases. There are some tips and tricks we can do to avoid this recurrence. For instance, the correct identification and resection of the ganglion stalk. Also, the resection of a small amount of the pathological dorsal capsula. And there are some authors trying to do a different thing. Some people pointed a potential role of the dorsal capsule scapholunate septum, and they say, what if we have to stabilize this structure in order to avoid a few of recurrences? That was our initial idea. We have been doing this for a while, and then we reviewed our patients. So we have a retrospective study with a small amount of patients, only 90 included patients though. We divided the patients into two groups. In the first group, Group A, we performed arthroscopic resection alone. And for the second group, Group B, we performed both arthroscopic resection and dorsal capsulodesis in a routine manner. Even if they had no instability nor laxity of the SL ligament at all, we performed this dorsal capsulodesis. And then we submitted the patients to a functional evaluation. These are our demographics. We have a very young group, mostly female patients. We have a follow-up period of around 30 months. That is a quite short follow-up period, though. These are our results. In the post-operative period, we have a significant decrease in pain for both groups, and there were no differences between the groups. On functional results, we have overall good results for all the parameters, for grip strength, pinch strength, and all the parameters of range of motion. All the values were above the 80% per year. DASH scores were quite low, 3 points and 2 points for the groups, and there were, again, no differences between the groups. So the overall results were good and were similar for all the patients and between the groups. And this data is already known in the current literature. Our data overlap present literature. On what concerns recurrence rates, we find out an interesting thing. For Group A, the group we performed the resection alone, we had a recurrence rate of 30%. We know it is quite high. The EWAS group is reporting lower rates, for instance, 9% and 12%, but there are still some reports claiming as high incidence as we claimed. For Group B, the group where we performed in a routine manner resection of the ganglion and also a dorsal capsulodesis, the recurrence rate were significantly low. It was only 11%, and this is a significant difference. This is an important data of our study. So now we think that besides doing the resection of the ganglion and also do the resection of the dorsal capsule, the pathological capsule, maybe we should try to do to do also the dorsal capsulodesis in a routine manner. Maybe by stabilizing the DCSS structure, we are doing a positive effect in the recurrence rate. This is our idea. So the main message of our study is that arthroscopic treatment allows us to obtain good functional results in general, and maybe we are trying to do this small modification in a routine manner. Of course, we know our study is a very small one. We have a small sample, and we have a very short follow-up period. So this is just an idea, a preliminary result. We have to enlarge this to more patients and to a longer period in order to understand if our results are valid and worthy. These are our references. And thank you very much for your attention. I wanted to leave with a picture of my city and my hospital, but last week I changed my mind. I put this picture of the Nations League because I think it's much more prettier. Thank you.
Okay, any question from the audience? Okay, yes, sir.
Thank you for your paper. It's really impressive and wonderful. I just would like to make one comment.
we are talking about dorsal ganglions as a unique situation. And I think we should consider dorsal ganglion as symptom of some pathology, and we should compare different kinds of situations. It's a totally different patient with a symptomatic and unstable scapholunate joint than another patient with a dorsal ganglion that is asymptomatic. And so we're talking about different pathologies. So I believe when you treat with a capsular disease a patient with scapholunate instability, you are treating an instability, not a ganglion. And that's why you probably have a better result. Thank you.
Thank you.
Any questions?
Following up on that same comment, are you really, is your capsulodesis only the DCSS, or is it the entire dorsal intercarpal ligament? Because it looked on your schematic that your sutures are actually grasping the dorsal intercarpal ligament. If that's true, I think I would agree with the previous question that was asked. You're really addressing some instability.
Yes, we used the technique by Professor Matulan. In fact, all our patients had dorsal ganglia anatomically related with SL ligament. We confirmed that by performing MRI to all of the patients. Clinically, they didn't have symptoms of instability. Watson test was negative. In arthroscopic, there was 2 patients with low-grade instability, only Geisler 1 and Geisler 2. But we don't know. The problem is that we don't know the etiology of the ganglia. We are here trying to assess different things and try to understand. This is a preliminary thing to the future.
Your pain relief was quite dramatic. Is there any effect of denervation, similar to Martin's question earlier? Is there any effect of denervation in the capsular procedure you're doing?
Oh, well, maybe. We are not sure. Maybe it is, but the pain was equal. The decrease of the pain was equal for both groups. That's a positive thing for us because we wanted to be sure that our modification was just acting in one aspect. I'm not sure if we do some denervation. We really, and I don't know how can we be sure of that. Sorry.
May I ask a question? When you take down the ganglion, you're also taking down the DCSS in a way, aren't we, or not?
Well, we try not to do that. We do a mid-carpal approach and radial carpal. We try not to damage the DCSS.
Thanks. Well, thank you very much for a thought-provoking series. Call on Dr. Alfonso Perez, the critical ligamentous stabilizers of the intercalated segment.
So good morning. My name is Alfonso Perez. I'll be presenting the following paper. So we know that isolated injuries to the scapholunate interosseous ligament are insufficient to produce dorsal intercalated segment instability. However, there is no consensus on which secondary ligament cells stabilizers are critical for intercalated segment postural changes in scapholunate dissociation. Thus, our purpose was to evaluate in a cadaveric scapholunate instability model the role on carpal posture of the long radial lunate ligament, the scaphotrapezoid ligaments, and the dorsal intercarpal ligaments. We also sought to determine if the lunate and scaphoid insertions of the DIC have a differential effects on lunate stabilization. So we studied 30 fresh frozen forearms, mean age 50, with no radiographic evidence of arthritis, no signs of scapholunate injuries under stress views. We used a dorsal approach, a small dorsal capsulotomy. We identified the scapholunate interosseous ligament, and it was cut from volar to dorsal to avoid any other ligament injuries. Then we identified the dorsal intercarpal ligament and was divided from the lunate insertion and then from the proximal pole of the scaphoid and waist of the scaphoid. The radial lunate ligament was identified from dorsal to volar, and it was cut also with a hook blade to avoid other ligamentous injuries. And the SCT was cut from a wall approach, and this section was confirmed by fluoroscopy. The specimens were randomized into 5 sequences of ligament section. Each group was of 6. These are the groups. All started with scaphoid interossous ligament division. And the wrists were mounted on a test frame with loads applied as described here. We took baseline fluoroscopic images, and after every ligament section, we cycled those wrists with loads and repeat the fluoroscopic images. The images obtained were AP with clenched fists and lateral with weights. So we measure radial lunate angle, and we define DC as an increase as an absolute value of radial lunate angle of more than 15 degrees. But because of baseline lunate posture, we also considered a normalized measure of DC, an increase in radial lunate angle of more than 15 degrees from baseline. We also measure scapholunate angle and scapholunate gap. So the measurements are expressed as mean and with confidence intervals of 95%. We compared the groups with ANOVA for repeated measurements, and we conducted a sample size calculation a priori. We found no significant differences in terms of age, gender, body mass index, or baseline and final measurements. So most important for radial lunate angle, we didn't find any significant change when only the scaphoid interossous ligament was cut, but the radial lunate angle increased significantly. The long radial lunate ligament increased the radial lunate angle, but not enough to produce DC. So we were able to produce DC according to IWIW with those ligaments combinations. And when we take into measure the normalized values, we found that the most important were the STT, DIC, lunate and scaphoid insertions, or a combination. And when we take into measure the individual increase, we found that the highest increase in radial lunate angle was when we cut the STT or both insertions of the DIC. About the scapholunate angle, we also didn't find any significant change in scapholunate angle when only the scaphoid interossous ligament was cut. And we did find an increase when the lunate insertion of the DIC was cut, or when the STT was cut, or a combination with long radial ligament. The scapholunate gap, also the scaphoid interossous ligament did not produce a significant increase on this parameter. And we found that we need volar and dorsal secondary stabilizers to be cut to produce a significant change in scapholunate gap. So as for conclusions, we found that isolated scaphoid interossous ligament did not produce DC. And in addition to scaphoid interossous ligament injury, we need disruption of at least one secondary stabilizer of the scaphoid or lunate to produce a significant lunate extension. The scapholunate angle increase was recreated when, in addition to scaphoid interossous ligament, the STT or the lunate attachment of the DIC were sectioned. And in our model, the scapholunate gap was noted when volar and dorsal stabilizers were injured. So, most important conclusion is there is no one scaphoid interossous ligament injury or scapholunate instability. There is a spectrum of radiographic manifestation of this dissociation and will depend on the secondary ligaments, secondary stabilizers injured. I'd like to thank all my co-authors and the financial support from the HSS Biomechanics Department and Joe Nguyen for his statistical support. Thank you very much.
Thank you very much. Questions from the audience? Perhaps, if I could, yeah, thank you.
I'd just like to say that it's a really fantastic study. But my question is, any idea how we're going to go in reverse and figure out what we should be reconstructing? Obviously, it doesn't make sense just to reconstruct the scapholunate ligament.
Well, actually, that's the best question I will do, because I'm also concerned, and it gives more questions than answer my work. Because as we think about maybe we should have any specific technique, and we should address which ligaments are injured before addressing any specific technique or addressing for tri-ligament tenodesis or PCO technique. But we need to address which secondary ligaments must be reconstructed before starting a new technique, but I couldn't do any recommendation with this work. Probably I would try to use an MRI or arthroscopic diagnosis before trying my reconstructive technique.
Scott, do you have any comments?
I think Alfonso said it all. These are not, scapholunate ligament ruptures and scapholunate instability is not a single entity and may underlie why after 40-some years of all the different attempts and all the different repairs that are out there, we still have a very frustrating rate of failure. And maybe it's because we need to understand better which secondary ligaments have been injured and then tailor our approach to those particular ligaments.
And the way to understand those better, would you think arthroscopy or?
I think MRI can be used, but it's very institution and equipment dependent. We have to have a radiology department that has really studied this and is able to show us quite a bit of detail in all of these accessory ligaments or secondary ligaments. I would actually call them critical ligaments. They're more than secondary. But I think arthroscopy has been demonstrated to do the same thing. In fact, Oberstraten just 2 or 3 years ago and colleagues showed an arthroscopic assessment of scapholunate injuries showed dorsal intercarpal and long radiolunate ligament injuries were the most frequent associated injuries.
Yeah. Especially in symptomatic ones.
Yes.
Symptomatic. Thank you very much, Dr. Perez.
The next study will be delivered by Marta Joko, wrist proprioception and forearm muscles, biomechanical parameters, dependency in DZ cases.
Thank you. Ladies and gentlemen, my work will be considering the muscle biomechanical parameters. And of course, there is no conflict of interests. And we all are talking about the wrist proprioception, wrist stability, and its importance for our patients. And thanks to previous researchers, we know a lot about the proprioceptors. We know about the cells which are responsible for proprioceptive stimulus. We know all about the mechanoreceptors, or we trying to know all about where they are, what's the responsibility, etc. And we know that there is a dynamic wrist stability, which is concerned with the SL ligament. And thanks to our Elizabeth Haggard, we know that there is a connection between the ligaments and between the proprioception. But the aim of our study was what to do when we've got the instability patients with ruptured ligaments or with problem with DC, and what's the biomechanical influence on those patients. And the problem is that usually most of our patients which are in this study, they were not connecting the pain issues with any kind of trauma. Only 10 out of 18 were thinking, okay, I had sprain or strain, or I had a fracture in the wrist area, but the trauma was more than 2 years before our examination. And at least 5 of our patients presented the joint laxity symptoms, and that's why we decided to gather 18 of our patients with DC symptoms considered with the biomechanical research, and the DC confirmation was done by X-ray or MRI, and the main reason of the surgeon appointment was the pain in the wrist area, and they assessed the pain at the 3 to 5 points in numeric scale. And we also assessed the control group, healthy volunteers in similar age with no previous wrist trauma, with no pain in the wrist area. And we used, for assuming the joint position sense as a part of proprioception, we used the three-dimensional upper limb movement Zebris system, and we decided to examine a very basic wrist movements divided into measured angle. And to assume the forearm muscle biomechanical parameters, we used the Biodex System 4 Pro, the isotonic protocol, with 4 repetitions in 3 trials with 15 seconds break. And what was the most important for us, the resistance made by Biodex was adjusted to patients' possibilities. And here you can see our results. So we observed a significant improvement of extensors biomechanical parameters. Here you can see the average peak velocity parameter and the first and last trial, and also a significant improvement of flexors work and flexors biomechanical parameters in average peak velocity. And it also was significant in other biomechanical parameters. But what we also observed was the muscle balance in the DC wrist, and there was a significant better balance between the extensors and flexors muscles and the DC wrist. But there was absolutely no significant difference in each of examined joint position stance, and each of them was there was no significant difference between the error of active reproduction of joint position stance. So to conclude our work, what it gives to us? It gives us we may assume that forearm muscle plays an important role in wrist stabilization, but we cannot think only about the muscles. We need to think all about the proprioceptors and mechanoreceptors. We know that disabled ligamentous stabilization may be supported by higher forearm muscles activation, and what I want to say that patients with higher pain rate decided to treat the DC operatively, but 12 out of 18 decided not to do the surgery. But what we need to remember that this is like the preliminary study, and this is really hard because we need to remember about the arthritis, slack, etc. So I hope maybe on the next Congress I will be able to show you the results after 3 years and more observation of those patients. So thank you very much.
Thank you for a very interesting study and one of a series of studies on this particular problem, and we hope that this will ultimately result in ways to treat these non-operatively. So my question is, the increased agonist-antagonist balance that you showed in your DZ individuals, is this cause or effect? In other words, your patients have already gone to full DZ.
Yeah.
If these were protective, perhaps they would not have advanced to DZ, or is it reflective of increased stress? And do you have an idea as to why you showed this?
I think it's an effect because as I were doing the research with them, they are telling that before pain and before everything, they weren't feeling such a big amount of power in their hands. So it was also implemental for them that they felt that they've got stronger muscles. I know it's not objective, like this is only a subjective they're saying, but they said that they feel that they are trying more to get rid of the pain, but they were not doing any training before this examination.
Questions from the audience? I would encourage us to move forward, consider a coupled motion path, dart throwing, circumduction.
Yeah.
Thank you very much for this interesting work.
Okay, thank you. The next speaker is Maria, a sophrologist from Spain. The topic is wrist traction interferes with arthroscopic evaluation and the surgical repair of the scapholunate ligament. Please.
Hello. First, I would like to thank the organization of this session for allowing me to present to you how does the arthroscopic evaluation, how does wrist traction interfere with the arthroscopic evaluation and surgical repair of the scapholunate joint misalignment. I have no disclosures. And it doesn't work, yes. These are the members of our couple biomechanics research team in Barcelona. I am going to present to you the kinetic cadaveric study that we conducted last year. We planned, to analyze if in scapholunate ligament deficient wrists there are any significant changes in the alignment of the scapholunate joint between carpal axial loading and carpal axial traction, to find out if the arthroscopic carpal axial traction may lead to underestimate the scapholunate misalignment clinically found in the scapholunate unstable wrists. To conduct this study, we spatially designed and constructed 2 different jigs which allowed us to fix, to axially load, and to tract 5 scapholunate ligament sectioned wrists kept in neutral forearm rotation. Any spatial changes in carpal bones alignment were monitored by an electromagnetic motion tracking device whose sensors were attached to the scaphoid and the triquetrum. This system allows us to monitor the angular 3D position of the sensors attached to the bones, so we can register the lunate, triquetrum, and the scaphoid flexion extension degrees, the triquetrum, lunate, and the scaphoid intracarpal rotation in pronation or supination, and finally, the triquetrum and the scaphoid dorsal or volar translation. We first actually loaded the wrist and checked, as you can see in the video, and see how sensors move under axial loading. And we then applied an axial traction, as you can see in this video. Also, sensors move under axial traction wrist. The results were assessed using a Wilcoxon sign rank test, and significance was set at P005. What did we find? When a scapholunate ligament deficient wrist is axially loaded, the scaphoid and the triquetrum both jointly flex. The scaphoid and the lunate rotate in reverse senses, and the scaphoid dorsoradially translates while the other first carpal row bones move volo-ulnarly. So, during axial loading, we find a radiocarpal and a midcarpal joint misalignments with a scapholunate joint gap secondary to reverses scaphoid and lunate intracarpal rotations. On the contrary, when a scapholunate ligament deficient wrist is axially tracted, all the first carpal row bones extend, supinate, and volarly translate as a block, leading to a radiocarpal and a midcarpal joint good alignment, and to a scapholunate joint 3-dimension alignment. This laboratory study allows us to conclude that in a scapholunate deficient wrist, the scaphoid and the lunate alignments are statistically significant different between axial carpal loading and axial traction. The 3-planes scaphoid alignment is completely reversed in both conditions, while the lunate is only modified in its flexion-extension plane. So we can conclude that carpal axial traction may lead to underestimate the scapholunate joint misalignment secondary to a complete scapholunate ligament disruption in a reducible wrist. When a complete scapholunate ligamentary wrist is put under traction, the expected scaphoid flexion and the scaphoid pronation and the scaphoid joint space gap that we should expect to find out because of the ligament disruption will disappear. So, in wrist arthroscopy, we should always completely release the wrist traction before testing the scapholunate joint gap through the midcarpal joint to facilitate the opening with a hook. And before, when we want to discard the presence of cartilaginous disease secondary to a dorsal-radial radioscaphoid impingement before indicating a scapholunate ligament surgical repair technique. On the contrary, we can increase the traction amount just before tightening and fixing our surgical scapholunate repair procedure to take advantage of the scapholunate joint reduction associated to the axial traction. Thank you very much for your attention.
Okay, thank you. Any question from the audience? Okay, yes, sir.
Please use the microphone, if you would.
Do you think is your suggestion for keeping the traction when you're tying your suture or reconstruction procedure, it also applies when you make capsule procedures?
The only thing that I say that is with axial traction, you reduce your gap and you reduce your, so yes, I think that yes, you can take advantage of the traction. It helps you to...
I understand that may work better when you do a ligament reconstruction with tendon grafts.
For a capsule procedure, I think they're the same. You are avoid having to pull your bones.
Thank you.
Please.
Thank you. In practice, because your cadaver model has a very simple situation in isolating the ligament, but in practice there are a lot of extrinsic factors. So in comparison to your 1 or 2 kilogram distraction or not, in practice, how much do you need to distract to give a false negative, and how much do you need to load axially to give a proper positive for impingement?
We only tracted 1 kilo because we don't have any muscles in our specimen to combine. And if we had really tracted all what we tracked during our arthroscopic procedures, it will be disrupted. And I haven't understood the final question.
Yes, that was it. So I just wanted to ask, in practice, what advice do you have to avoid the false negative and to confirm the positive findings?
I really do not understand what you are asking me. Excuse me. What?
How much do you have to distract in practice?
In my practice, I distract a little bit, at least as I can. Is that?
I think the question is, what is the advice for the clinic, for the clinic practice during the surgery?
It's an experimental. What I have presented is an experimental work.
I think the advice also showed in the presentation that just release the traction tower when you're doing the assessment of the scapholunate.
But again, this is a cadaveric experiment, so we can't extrapolate exactly to the clinical situation. Dr. Borelli.
Maria, congratulations for your presentation, but I just have a question. What about the diagnostic validity of the dynamic test, traction test, about the interruption of the Gilula arc? Is it not valid anymore? Because if you make traction, what about the dynamic validity of the dynamic test when you apply traction and you see the interruption of the Gilula arc? That is one of the possibility to have diagnostic.
I think I say the same. It's a cadaveric study. I am explaining what we find, and with only 1 kilo traction, it all disappears.
Yes, the difference is that 1 kilo maybe this is the
yes,
result.
but they are cadavers.
Yeah, yeah.
But this makes me suggest that we must release our tractions before taking some practical decisions.
Thank you.
Thank you, Maria.
Maria, I have one more question.
Yes.
Colombo here. So, a beautiful study. I would encourage you, based on the last presentation, to consider dividing some of the secondary stabilizers and repeating the process to see whether that changes the adaptive positions with loading and axial traction.
Okay, that's a good idea.
Thank you very much for your presentation.
So next we'll call on Dr. Shuko Xing from China. Thank you. In vivo length changes of scapholunate interosseous ligament during wrist flexion extension.
Good morning, everyone. This topic is all about the scaphoid unit ligament. I should say this work was performed by my colleague, but because he, for some reason he cannot come here for the visa, so I give the speech for him. In vivo study has confirmed that scaphoid and the unit move primarily in flexing or extension. So this study purpose is to investigate the change in the length of the palmar, proximal, and dorsal subregion of the scapholunate interosseous ligament in healthy human subject during the wrist flexing or extension in vivo. We obtained CT scans in 6 wrists of healthy volunteers. These 2 tables show the inclusion criteria or the exclusion criteria. The scans were performed with the wrist at 5 positions from 60 degrees of flexion, 30 degrees of flexion neutral, 30 degrees of extension, and 60 degrees of extension. We extracted 3-dimensional images of scaphoid and lumate with software. The passes of 3 different fibers of the SIL were modeled. The length of each bit of the SIL between their respective origin and insertion points were measured and compared among different positions of wrist flexing and extension. We marked the origins and the insertions of these ligaments on the surface models of the lunate and scaphoid. Each subregion of SILI was divided into 3 portions respectively. The center of each portion was plotted with point. We then connected this point to model the path of each of the 9 ligament portions. We directly measured the shortest path of the ligaments. This method statistical analysis was used in the ANOVA. This table showed the length of the subregions of SIL at neutral position and the length changes during the wrist extension and flexion. From the extension of 30 degrees to the flexing of 60 degrees, the palmar subregions of SIL lengthened significantly. Also, from the neutral position of flexing of 60 degrees, the proximal subregions of the ligament lengthened significantly. From neutral position to the extension of 60 degrees, the intermediate and the dorsal beams of proximal subregions lengthened significantly. The dorsal subregions of the ligament lengthened or shortened not significantly. In this study, we found when the wrist moved from 60 degrees of extension to the 60 degrees of flexion, the dorsal side did not elongate or shorten significantly relative to the neutral position. Our result is agreement with the observation that the dorsal region of the ligament is often injured because of the less length to place greater strength on it. We also found all the beams of the proximal SILI did not elongate or shorten relatively to the neutral position. This suggests that wrist positions between 30 degrees of extension and 30 degrees of flexion are the best position with the least strength of proximal ligament. We believed that the position from 30 degrees of extension to 60 degrees of flexion will reduce the strength of healing ligaments. Based on our study, we are suggesting that the different tiers of SIR will need different wrist position to reduce the strength and promote healing. If the palmar SIR injury, the slight extension of the wrist is the best position to immobilization. If the proximal ligament injury, the neutral position is the best position to immobilization. If the dorsal ligament injury, the special position of the wrist will not needed. We like to immobilization the wrist neutral or slight flexion. If all the ligament injury, the neutral position may be the proper position. The limitations of this study is that a limited number of wrist position was obtained because of radial exposure. There was a small sample size. The length of ligament is measured by simulator rather than by direct measured. This conclusion is that during the wrist flex extension, the length of the palmar and proximal subregion of the ligament changes substantially, but the dorsal subregion changes minimally. Thank you for your attention.
Thank you, Doctor, for a very interesting study.
Thank you very much. One small question. Does that mean that SL ligament have some elasticity and it's elongate, and or that means that you have measured the gap between the bones and the position of the points of fixation between the bones?
Thank you for your question. So we used another software to map the incision and the regions. So during the flex or extension, the regions or the insertions did not change. Thank you.
That's about the elasticity of the ligament. Does it elongate by itself? Or the gap is changing just because of the position of the bones?
So the question is, does the natural ligament naturally elongate with movement or not? Is it very stable, or is there some laxity?
Actually, this is the biggest of the CT scan for this kind of study.
So you've shown that the dorsal ligament is substantially more stiff than the proximal or palmar ligament. Do you think that has implications in terms of the rate of loading? How quickly the ligament is loaded in terms of which ligament will release first? Which will rupture first?
Do you just make a correct diagnosis or something? Sorry.
Other studies have shown that the ligament is associated, that ligament ruptures are associated with rate of loading. So if the dorsal ligament is more stiff, that would imply that the dorsal ligament would rupture first in rapidly loaded situations. Do you agree with that? Have you done any work on that?
Okay, so actually, according to this study, because without any load, so it is unload. So this study shows the dorsal side may be more stiffness. So in my opinion, yes. So
I think so.
Yeah.
Other questions? Okay, thank you very much.
Thank you.
Our next paper is going to be delivered by Sheena Sikora from Canada, and a new twist from down under.
Guten Tag, thank you for having me today. I am from Canada, and this is a project from my fellowship in Melbourne, Australia. I'm excited to present it to you today. It's a novel device for testing for dynamic scapholunate instability using X-ray. We have nothing to disclose. And this technique was recently published in the Journal of Wrist Surgery in February of this year. Scapholunate instability is the most common form of carpal instability, and early detection can direct patients towards a scapholunate stabilizing procedure, which may prevent the development of a slack wrist. Wrist arthroscopy is currently the gold standard diagnostic test, but for non-invasive testing, 3T MRI so far is best. When read by an MSK radiologist, its sensitivity is 88% and specificity is 100%, but access remains limited in many public systems. Early scapholunate injury is often occult on static wrist x-rays unless the secondary stabilizers are also damaged. Dynamic views are frequently used to increase the sensitivity of detection. Current common x-ray series to diagnose these injuries include a PA, oblique, lateral, and dynamic clenched fist. There are also radial and ulnar deviation views that can be performed. Our objective was to develop a set of X-ray views with increased sensitivity and specificity for dynamic scapholunate instability and compare the performance of these views relative to routine static and dynamic views as well as MRI. In a review of the literature, the clenched fist view accentuates the scapholunate gap by driving the capitate into that disrupted scapholunate interval. It is difficult to standardize due to variability in wrist position, but this has been modified with an elevation of your hypothenar eminence 20 degrees to improve your visibility of the scapholunate interval. The pencil clenched fist view, which you can see on the right, combines the clenched fist view with the optimal pronation angle, slight ulnar deviation, as well as it images both wrists to rule out congenital laxity. This view has currently been reported as our best X-ray test when done at 30 degrees of ulnar deviation. This is our device. It's based on the concept of patients having increased pain when attempting to open a jar. It's a jar-sized lid, akin to Vegemite or peanut butter, attached to a bar which is stabilized by the patient's other hand. The radiographer then positions the patient and gets them to twist open the lid, but it must be done in supination. So why does this work? First, the force. The nice jar-sized lid fits comfortably in the patient's palm and increases the amount of force that they can put through to drive that capitate into the scapholunate interval. Thenar placement is optimized, allowing a proper view of the scapholunate interval. Ulnar deviation slides the scaphoid along the scaphoid fossa and away from the lunate. And supination uses the power of ECU as a distal carpal pronator, which was recommended to us through Dr. Garcia Elias's work. Patients were referred to our center by one of 5 orthopedic hand surgeons, and the inclusion and exclusion criteria are listed there. Exclusion criteria being anybody with a more advanced pathology, a slack wrist, or a static deformity. All intervals were measured at the midpoint by a single MSK radiologist, and patients received all wrist views, including PA, lateral, radial and ulnar deviation views, the pencil clenched fist view, R-twist views, and also a second either MRI or ultrasound diagnoses. We have very early results. We do this test quite a bit, but of course only so many of your dynamic tests will be positive. We have 4 patients to present to you today. Their mean age was 36, all were male, and all had a history of wrist trauma, dorsal pain over the scapholunate interval on palpation, and a positive Watson shift test. The mean time from index injury to presentation was 6.5 months. The mean scapholunate interval on a PA view was 1.8 millimeters, with the pencil clenched fist view was 1.5, with our twist view it went up to 6.3. Here are the case examples. First one is a 39-year-old male with a hyperextended wrist injury. His PA view showed 1.5 millimeters. The pencil clenched fist view showed 2.8 millimeters. Our twist view showed 6.4 millimeters with an MRI confirming a complete tear. Second patient with a fall off a motorbike, the PA view showed 1.5 millimeters. The pencil view actually only showed 1 millimeter. Our twist view showed 4.6, with again an MRI confirming a complete tear. Patient 3 is a 29-year-old male who had an injury while fencing. PA view showed 1.5. The pencil view showed 1.3. The clenched fist view alone showed 2.0. Our twist view went up to 8.2 millimeters with an ultrasound showing complete tear. Last patient to show you is a 39-year-old male who presented 6 weeks after a fall onto an outstretched hand. PA view showed 2.8, pencil view 1.5, clenched fist view 4.1, and the twist view went up to 6. MRI again showing complete tear. For comparison, I did want to show you one patient without a complete tear. Here the PA shows 1.8 millimeters. The clenched fist shows 1.1. The pencil clenched fist went up to 2.5. The twist view went up to 3.8. And the MRI reported degeneration of the dorsal ligament, but intact membranous and volar portions. So in conclusion, the twist views are easy to perform, and the device is simple and easy to make. Our early results show the twist X-ray to demonstrate substantially greater gapping of the scapholunate interval compared with the clenched fist and pencil grip views, which were often normal. It correlates positively with clinical and MRI results. And we are continuing to collect data and assess if the twist views should be incorporated into the general workup of scapholunate instability, thereby directing management decisions and preventing delay in diagnosis and expense from MRI. Of course, we had a small number of patients, and controlling grip force was not done. There's our references. And a quick plug to invite you to the forthcoming Asian Pacific meeting in Melbourne next year. Thank you.
Thank you very much for introducing a seemingly quick, easy, and sensitive way to diagnose dynamic instability. I guess my questions would be, number one of the benefits of the pencil grip, as you pointed out, is you get bilateral views. Do you recommend doing this on both sides? And in your studies, did you show that the normal wrist also showed an increased gap with the twist view? And the second question is, what do we do if we don't have access to Vegemite?
For your first question, we only studied the injured wrist in this study, but I personally always image both wrists, even if I'm just doing PA views, lateral views for comparison, because I do agree that there is some congenital differences sometimes that can really throw you off. So I would recommend doing the twist view on both sides.
Questions from the audience, please.
Excuse me, have you ever tried this in pronation as well? And if you did, there's any difference between both?
Yeah, we started this in pronation, and our results were, we were getting definitely bigger gap, but I had presented this at a meeting in Australia, and Dr. Garcia Elias was there, and he's the one who told us about supination, and you can try it with your own hand, putting yourself in pronation and twisting, and then if you flip it over, you can actually get further, and you harness that force, so it just creates that gap even more.
And you could measure this in pronation and supination by the early ones?
Like compare the two, you mean?
Yes.
Yeah, we could do that.
But you did? You have this?
We haven't done that, no.
Oh, all right, thank you.
Yeah.
Thank you very much.
Thank you.
Okay, next speaker is Federico Pila from Italy. His topic is about scaphoid fracture with scapholunate ligament involvement, instability, or ligamentous laxity.
Good morning. Scaphoid fracture represents the most common type of fracture of the carpal bone in active adults. The impact of tenor side of wrist causes hyperextension, ulnar deviation, and intercarpal supination. Some surgeons believe that the percutaneous reduction and fixation could increase the clinical result and reduce the healing problem in active patients. This procedure reduces the damage of scaphoid vascularization and the risk of ligament lesion. Arthroscopy is a useful tool to management this fracture, not only for the checking the reduction, but also for identify osteochondral or ligament lesion. We investigate when we found a ligament alteration in arthroscopy if is actual lesion or just instability. And if we use the pinning when is alteration of the ligament alter the result. We performed a retrospect study on 59 patients with a mean age 53.1. The surgeon from 2010 to 2016 from the same surgeon. The inclusion criteria is the fracture of the scaphoid body. The exclusion criteria, the proximal fracture, pseudoarthrosis, or arthritic degeneration. The patient divided in 4 groups. The group A is with a fixation with a percutaneous screw without the use of arthroscopy, 10 patients. B group, arthroscopy assisted fixation with a percutaneous screw without sign of scapholunate ligament lesion, 9 patients. Arthroscopy assisted fixation with a percutaneous screw with a sign of partial scapholunate ligament lesion threatened through the pinning, 10 patients for group C. And group D, arthroscopy assisted fixation with a percutaneous screw with a sign of partial scapular ligament lesion, not treated. The rehabilitation protocol is the same for the ABD group and consists of a series of home exercises given to the patient by our psychotherapy center. Brace immobilization for 7 days. After this period, the brace could be removed for a short session of active immobilization of the wrist. After 15 days, continual passive flexion and extension of the wrist was integrated. At 1 month after surgery, muscular exercise were started. After 3 months, heavy-duty work and sport activity were considered. For group C, the brace immobilization for 6 weeks. After 6 weeks, the Kirchner wires were removed. A rehabilitation protocol like the one adopted for the other group was used. Is a case from group A, is a player of soccer. A case from group B, a motorcycle. Another case from C group is a snowboard rider. A case from the group is another motorcycle. We analyzed the clinical score and the measure obtained in the post-operative, and the comparison is from A versus B or C or D, for C if the present absence of arthroscopy can influence the result, and C versus D, the present or the absence of the pinning. The difference between the 4 groups are not statistically significant. The incidence of scapholunate lesion in scaphoid fracture in literature is variable. In our patients, separate rates of scapholunate lesion were reported. There is not a statistically significant difference between our patient treatment with arthroscopy assisted and those traditional treatment. The advantage of arthroscopy is fructus reduction, arthroscopic control of guide wire axis, absence of protrusion of the screw in the joint, absence of associated ligament injuries. The advantage provided using arthroscopy can be justified for the treatment of scaphoid fracture in active patients. Thank you.
Okay, thank you. One short question for you. Sometimes we will find that there is dislocation between the carpus when there is scaphoid fracture and ligament rupture. So did you find that such a kind of case in your series?
I don't understand.
I mean, sometimes there is dislocation of the carpus, like a scaphoid paralunate dislocation. Did you find this kind of case in your series, and how could it be achieved? How could it achieve the reduction of the dislocation without open surgery?
I don't remember the exact number of the case.
No such cases.
I don't remember how many we have found.
Okay.
Do you think there's a risk in putting extra K wires across the scapholunate when you have a proximal, you have a pole fracture there, and do you think there's an increased risk of fracturing that pole? And what size K wires do you use?
We reduce only we have used this technique on the body fracture. And we use 1 pound, 2 or 3 K wire.
Thank you. Thank you. I'd like to call on our last speaker, Dr. Fidel Cayón from Ecuador, Acute Scapholunate Dissociation, Assembly, and Effective Option for its Treatment.
Thank you. Hello, I'm Fidel Cayón, and I come from Ecuador, a little South American country not much known for hand surgery in these days. Now, I'm convinced that we are working to make Ecuador a hand surgery leader in the world. I represent Ecumano, and yesterday, these new times for Ecuadorian hand surgery began with the acceptation of Ecuadorian Hand Society as a member of the IFSSH. I have to thank Colombia, Chile, Venezuela, Mexico, and España and Argentina that give me a hand in this. All the international representations of the hand societies give the welcome yesterday to us, so many thanks to you, and I'll be sure the Ecuadorian work will be important for world hand surgery. Okay, now we'll talk about an A assembly. This is a kind of surgical immobilization that we can use in an acute scapholunate dissociation that is the most common cause of carpal instability. We think that an A assembly is an easy way to recover the carpal kinematics and allow to heal the broken ligaments that are involved in this pathology. It's important to remember that in a ligament lesion, the healing capacity evolves quickly in a 3 weeks period, allowing us to restore the ligament continuity and having a good healing for restore the carpal kinematics. The scapholunate ligament has an U or C form in what the dorsal part is the most important for its strength. Then we have a partial lesion just only in this dorsal zone. We have difficult to diagnose because of the resistance that the rest of the ligament gives to the joint. The problem is when the rest of the ligament fails and the scapholunate joint shows as the dissociation, but in this moment it's too late to restore the kinematics, only with immobilization because the impossibility of the ligaments to heal. In the cases we found the lesion as quick as in the first 3 weeks, this is an acute period, we have to restore the anatomy and immobilize the scapholunate joint with K wires. First, like an axis between the two bones. That is important because it allows to join a scaphoid with the lunate. And after that, we use 2 K-wires more using the capitate as a fixator in this case. This we call a assembly. This is a very good option that allows us a small movement of the radiocarpal joint that is good for the recovery of the patient. We evaluate the results obtained by images, the strength in the hand, the pain, and the range of movements in the cases operated by our team and evaluate the results of this treatment. This is an example of one case of scapholunate dissociation accompanying a scaphoid fracture in a 22-year-old male patient. He had a break through an accident in a motorcycle. We used the A assembly restoring the carpal kinematics, and in this case, a screw for the scaphoid. In our 7 cases, we found a reduction of the joint in 100% of the cases immediately after surgery. 3 months after the injury, only 1 case had scapholunate dissociation. Also, clinically, it remained asymptomatic. The pain was 2/10 in the visual analog scale. The range of motion averaged the 80% of the contralateral side, and the strength reached 80% on the contralateral side. In conclusion, we think this is a valid option to solve this problem. We found the most important problem now is to diagnose the problem during this 3-week period. But now we are performing a wrist arthroscopy to try to make a very quick diagnosis. In the patients with distal radius fracture or with the scaphoid fractures or with wrist trauma with highly scapholunate dissociation suspected, we perform now an arthroscopy. We are sure that this will allow us to diagnose much more cases than in other way can be diagnosed too late. I don't have more to say that in Ecuador, all of you are welcome. We have a little country, but a very big heart. Thank you.
Thank you, Dr. Perez. Could we have any question from the audience? One last question. Scott, do you have a comment?
How acutely do you need to make this repair in order for it to be successful? And why do you think that pinning leads to healing of the scaphoid? What do you have? Let me go back. How quickly do you need to repair this? And do you ever do a repeat arthroscopy to assess your scapholunate healing?
We didn't do arthroscopy. And we have to check and diagnose this before the 3 weeks period. It's before 3 weeks.
2 weeks, okay.
Okay. We said that after 3 weeks, the healing capacity of the ligament is so much less than in that period of 3 weeks. And the problem is to diagnose that rupture of the ligament in this period of 3 weeks. Then now we are trying to assess the fractures of the radius, the fractures of the scaphoid with arthroscopy to evaluate the ligament and to be sure that it's not broken, or if it is broken, make an A assembly.
And am I correct, these were closed reductions? With closed reduction with percutaneous K-wires?
Yes, closed reduction with percutaneous.
Well, I'd like to thank you very much for that presentation, and thank you to the audience and to our speakers for your excellent presentations this afternoon. Let's enjoy lunch.